JK is 26 years old, but he reports feeling like his body is failing him. He suffers from a severe progressing unsteadiness, a loss of balance and spatial awareness that becomes significantly worse the moment he steps into a dark room. The physical instability is paired with a sharp cognitive decline. Over the past 6 months, he has developed difficulty articulating his thoughts and a severe drop in concentration and short-term memory loss that erases conversations from the day prior. Looking at his medical chart, his physical examination reveals 2 distinct clusters of distress. In the hematologic column, we see noticeable skin pallor, mild jaundice yellowing the sclera, and a painfully inflamed beefy red tongue known as glossitis. Opposite that, the neurologic column lists his ataxia, cognitive decline, and a creeping numbness in his extremities. At 26, the specific combination of jaundice, a raw tongue, and a loss of balance in the dark suggests a process that crosses the boundary between the vascular and nervous systems. The red blood symptoms and the blue nerve symptoms present as 2 completely separate diseases, but they are driven by the exact same systemic failure. JK is suffering from a complete vitamin B12 deficiency. His body has exhausted its stores of the vitamin, triggering a catastrophic dual pathway enzymatic collapse. To understand how the absence of a single vitamin dismantles both the brain and the blood simultaneously, we have to trace the mechanical failure of his body's absorption cascade. Moving B12 from a meal into the bloodstream requires a specific sequence of physiological checkpoints. A failure at any one of these nodes halts the entire process. The first checkpoint is ingestion. B12 is synthesized by bacteria and accumulates in animal proteins. JK's dietary history reveals 4 years of meals consisting mainly of donuts, potato chips, and beer, with virtually no meat or dairy. His initial intake is already severely compromised. After ingestion, B12 reaches dissociation. Entering the stomach, it is tightly bound to food proteins. Gastric acid must dissolve those proteins to release the B12, but JK's daily use of famotidine, an H2 blocker, mechanically inhibits acid-producing cells. Without an acidic environment, food proteins never dissolve. The scarce B12 remains permanently trapped inside its protein matrix. Consequently, a transport protein called intrinsic factor cannot bind to the shielded B12 molecule. Because JK's B12 is physically shielded, the critical binding phase is completely bypassed. The B12 intrinsic factor complex is meant to travel to the end of the small intestine, the terminal ileum, where it is finally absorbed. In JK's case, the terminal ileum has nothing to absorb. A sustained, unbalanced diet combined with daily heartburn medication created an impenetrable mechanical block. This completely starved his bloodstream of vitamin B12, creating a systemic vacuum that set the stage for a catastrophic, body-wide cellular collapse. Once the bloodstream is starved of B12, the first systemic consequence is hematologic failure. Vitamin B12 is a mandatory cofactor for methionine synthase. Without it, this enzyme stops, creating the folate trap. The stalled gear causes the active folate pipeline to back up, trapping the supply. Without active folate, the cell cannot produce thymidine to build DNA, strictly halting replication inside the nucleus. However, out in the cytoplasm, RNA and protein synthesis continue at an unchecked, perfectly normal rate. This creates a biological mismatch called nuclear cytoplasmic asynchrony. The cell physically grows to divide, but its frozen DNA prevents the final split. This asynchronous growth forces the bone marrow to produce giant, malformed red blood cells, known as macrocytes. These macrocytes are massive, but structurally incompetent. Their immense size makes them incredibly fragile, causing them to suddenly rupture and die prematurely. When these giant red blood cells violently burst out in the bloodstream, they release large amounts of bilirubin into the blood. That excess bilirubin is exactly what caused the mild yellow jaundice visible in JK's eyes. This rapid cell death extends to all rapidly dividing tissues. The mucosal lining of the mouth requires constant cellular turnover. When that turnover fails, the tissue degrades, resulting in the painful, beefy red glossitis on his tongue. The folate trap clearly maps to the severe anemia and his visible physical decay, but it does absolutely nothing to explain why he is losing his balance in the dark or why his memory is fading. To find the source of his neurological symptoms, we must look into the central nervous system, where B12 starvation triggers a darker failure. Vitamin B12 is the mandatory cofactor for a second enzyme, methylmalonyl-CoA mutase. As B12 drops to zero, the substrate it processes, methylmalonic acid, or MMA, rapidly spikes to toxic levels. This excess MMA forces a structural compromise. The body begins incorporating abnormal, odd-chain fatty acids into the myelin sheaths, the dense insulation surrounding the nerves. These abnormal fatty acids are structurally weak, causing the myelin to physically break down and peel away. Without myelin, nerve signals misfire and die. This demyelination targets specific zones in the spinal cord. It begins in the posterior columns, which carry signals for vibration and joint position. When they dissolve, the brain loses track of limb position in space. This causes his sensory ataxia, relying entirely on vision to walk. Without visual anchors in the dark, he falls. As destruction spreads to the lateral columns, motor pathways degrade. This lateral column damage maps directly to the progressing weakness and tingling paresthesias creeping up his lower extremities. Left unchecked, this demyelination advances into the cerebral cortex, destroying neural networks required for memory and inducing a severe cognitive decline known as megaloblastic madness. This specific pattern of neural decay is called subacute combined degeneration. If the deficiency isn't corrected quickly, the death of these nerve tracts becomes permanent. B12 and folate deficiencies produce identical cellular signatures on a standard blood smear. Both trigger the same folate trap and identical cell swelling. If a doctor mistakenly treats a B12 deficient patient with folate supplements, the folate trap will clear. The bone marrow will resume normal DNA synthesis, the giant macrocytes will disappear, and the anemia will seemingly cure itself. But resolving the anemia masks the true threat. Folate does absolutely nothing for the methylmalonyl-CoA mutase enzyme. Without B12, the toxic fatty acid will continue to accumulate, and the patient's spinal cord will silently and irreversibly degenerate. To tell them apart, physicians rely on a diagnostic matrix mapping two specific metabolites, homocysteine and methylmalonic acid. Because both B12 and folate are required for the methionine synthase pathway, a deficiency in either one elevates homocysteine levels in the blood. Homocysteine confirms the anemia, but cannot differentiate the cause. The differentiator is methylmalonic acid. Folate is not involved in the MMA pathway. Therefore, an elevated MMA level is the exclusive definitive footprint of vitamin B12 deficiency. It is the biochemical alarm bell signaling the active destruction of the spinal columns. Returning to patient JK, we can now perfectly map his physical deterioration to his cellular chemistry. Years of poor nutrition, paired with daily over-the-counter antacids, neutralized his stomach acid. This severed his body's ability to extract B12 from his food, creating an impenetrable absorption blockade. A vitamin B12 deficiency is a profound mechanical failure. By disabling just two enzymes, it systematically starves the blood of functional DNA, and physically unravels the insulation of the nervous system. It is a precise demonstration of how routine, everyday choices can trigger severe molecular consequences.